Thermal burn is defined as the tissue damage caused primarily by denaturing and coagulating cellular proteins and secondarily by causing vascular ischemic damage. Causes: heat, electricity, explosions. Superficial first-degree burns, commonly caused by sunburn or short-duration flash burns. Dry burns with edema and no blistering, erythema and pain are common, heals in a week accompanied by superficial peeling and no scarring. Partial thickness, second-degree, burns, causes include longer duration scalds and flame injury. Blisters and weeping of the skin, intense erythema, significant pain, and temperature sensitivity, heals in 1 to 4 weeks, with little scarring, but pigmentary changes common. Full thickness, third-degree, burns, commonly caused by chemical, electrical, flame, and scald injuries. Skin appears dry, inflexible and leathery, with little or no pain. Heals with significant cicatrization and scarring. Spectrum ranges from mild punctate/confluent defects, for example most cigarette ash injuries, to severe limbitis and permanent opacification, stromal melting or perforation, for example from molten metal, which may form a complete cast between lid and globe. Conjunctival injection, ischemia, the eye may be white, chemosis, necrosis, and cataract, if severe. Exposure keratopathy may occur acutely if there is significant loss of lid tissue, or as a late complication of lid cicatrization. Management. It is vital to first assess the extent of the burns injury. If there is any suspicion from the history or examination that the mouth/airways may have been involved, immediate anesthetic assistance is mandatory with a view to assessing and stabilizing the airway. Inhalational burns injuries can lead to airway edema and fatal airways/respiratory compromise. Superficial burns, cool compresses, lubrication, pain control. Partial thickness burns, topical antibiotic ointment, copious lubrication plus or miniseclusion dressing or moisture chamber, trim eyelashes if singed, lash particles cause irritation, consider lid suture or temporary tarsorrhaphy if risk of corneal exposure. Full thickness burns, as for partial thickness burns plus debride dead tissue and eschar, protect the eye with lubrication, Gelinit and Geliperm dressings, and tarsorrhaphy. Refer to oculoplastic team for specialist assessment, including skin grafting. Complications: loss of lid tissue, leads to corneal exposure. Lid cicatrization, leads to entropion/ectropion, trichiasis, and corneal exposure. Epiphora, from damage to the punctate/lacrimal ducts. Conjunctival burns, cicatricial changes, symblepharon, and severe dry eye, through damage to goblet cells, accessory lacrimal and meibomian glands, significant limbal ischemia, conjunctivalization, vascularization, and opacification of the cornea. Thank you.